Thanks. No, I was relaxing because I thought you were going to have the lung cancer panel first, but I'm happy to be up here, and thank you again for the invitation. Before I start, could I just have a show of hands? How many of you are involved at all in lung transplantation in your practice? That's good. So it looks like about probably 10-15% of you. Well, even if you're not involved in lung transplantation, I think I'm going to show you something that will at least be of a curiosity or interest to you to see how transplantation has evolved and where we are taking things now. So what I'll cover really is why ex vivo lung perfusion, and also look at changing the paradigm in the way we do transplantation and our approach to organ preservation, moving away from focusing on slowing down the death of the organ to really looking at focusing on repairing and regenerating the organ before we put it in. And really also bringing forward the concept that we have entered the era of personalized medicine for the organ, the ability to diagnose and treat problems with the organ that are in a targeted way before you transplant it, and also some of the potential spin-offs from the work that we've been doing. We have received support from a number of areas related to what I'm going to speak about. Vitrolife has provided us research support and supported our clinical ex vivo trial. Dallas Canada has given us a number of research grants. I hold the CIHR Wyeth Chair in Transplantation Research, and Excel and Exceed Molecular have provided research grants for some of the molecular diagnostics I'm going to show you. So in the Toronto Lung Transplant Program, we've been very successful in the last few decades in doubling, quadrupling the number of transplants we perform this year, and I think it's even going up higher. We've already done 25 lung transplants in the first 2 months of this year. Yet we still have a problem. This graph shows you that there are far more people that need a lung transplant and can benefit from lung replacement than we have organs for. So in green, the number of patients listed in our program, blue, the number transplanted in that particular year, and in red, the number of patients that die on the waiting list, which is around 20% on average. So one of the three of the fundamental problems with the way we approach organ management today, as I mentioned, is the focus has been on slowing down death rather than facilitating recovery of the organ. And the second thing is cold preservation, which has been the cornerstone of how we preserve organs, really is static cold preservation. You cool the organ down to 4 degrees, metabolism slows down to 5% of normal, you shut off the dying process, but you also shut off the ability of the organ to repair. And that really has hindered any active strategies to heal the organ. And most importantly, in lung and heart transplantation, we only find out how the organ works after we implant it. And that obviously makes us conservative in which organs we choose to transplant. So what I'm talking about now is not really preservation or trying to make the organ, maintain the organ at the level that you found it, but really can you improve the organ, resuscitate it, or even engineer it to be a better organ than what you started with to be able to handle the stresses and the novel insult that transplantation presents. Now, our biggest problem, as you know, is when we are faced with a multi-organ donor, we have to make our decision about transplantation right there, and we don't have very much time. After you flush the organ, you don't get a second look at it. So the majority of thoracic organs are declined at that stage of the process. So we looked at this possibility that if we had more time to diagnose and treat the organ outside the body, would we have a better opportunity to find the organs that are good, treat them, and also confirm that they're better before we transplant them? And so what that'll do is, instead of rushing and making your decision on a limited amount of time with a limited amount of information in an injured organ, really move the decision process down to in the ex vivo stage, and also then repair the organ and reassess it, and therefore hopefully transplant most of the organs and decline far less of the organs. So we set out to develop a system to keep the lungs out of the body, to be able to evaluate and treat them. And this work was done by Marcelo Sipple, who's now on our faculty. And we developed a simple system using equipment that everybody who's doing a lung transplant has in their hospital. So a standard ICU ventilator, a standard centrifugal pump, a cardiopulmonary bypass-like machine, and a chamber where you keep the lung in the circuit. We run the cardiopulmonary bypass backwards in effect, because you sweep the membrane with a hypoxic gas mixture and add carbon dioxide, so you can measure the lungs' function in terms of ventilation and oxygen. And we perfuse with 40% of cardiac output and a protective ventilatory strategy. So everything that we've learned about protecting the lung, maintaining the lung, we've put into a circuit to try and maintain it, not stress it, maintain it. And this is probably the most important slide that I'm going to show you today. This was the breakthrough. This was Marcella's work. And for those of you that studied isolated lung perfusion, and I know Steve Cassidy will enjoy this work because he was involved in some of the early work in our lab. So the lung dies in about 20 minutes at 37 degrees. And what Marcelo did here is he put pig lungs on a circuit in this new circuit at 37 degrees for 12 hours and showed that you maintain normal function of the lungs with an acellular perfusate outside the body for 12 hours. That had never been achieved before. You always would see a decrease in function. We also showed that whether you assist it with red blood cells or without red blood cells in the circuit, you get the same number. You're measuring the oxygenation and the dissolved fluid content. And so the acellular perfusate gives you an appropriate blood gas readout. And most importantly, when you transplant these lungs after 12 hours at 37 degrees, they function normally in the pigs. So we now have a system to keep the lungs alive at 37 degrees for 12 hours without causing significant damage. He then took pig lungs that we preserved in the standard way with the Perfidex solution that we developed, cold static preservation for 12 hours. And then for the second 12 hours, the lungs either got an additional 12 hours of cold static preservation or 12 hours of ex vivo normothermic lung perfusion. And we were looking for equivalence, but really we were surprised to see that the lungs at that time, the ex vivo perfused lungs, actually performed better after transplantation than lungs that had 24 hours in the cold. So for those of you that haven't seen it, this is what the system looks like. These are human lungs that were turned down for transplantation, put on the circuit. And here you see the fellows are actually, you can bronchoscope the lungs for toilet, for sampling, treatment. Here they're delivering the adenoviral gene therapy that we're studying, putting a little aliquot, a vector in each airway segment to treat the lung. And over time, you can continue to evaluate the organ and evaluate the effect of your treatment. So we took it to the clinic, and this is the system again. There's the dome with the lung in it, inspired by the Toronto Sky Dome, for those of you that know it. There's a monitor, there's the standard ventilator, and the centrifugal pump. So standard equipment in our operating room. And in 2008, we started the clinical trial. Again, there's Marcelo Sipple. That was his thesis work. Jonathan Young just finished his PhD also doing the gene therapy work. And they had the pleasure of bringing this whole project clinically in our hospital. Here you can see Tom Waddell. He's also doing it. And Marcelo there on one of the ex vivos. And we actually have the Waddell ex vivo technique, which is let's look at it for 1 hour longer, and then he gets to take his kids to school and show up for the lung transplant at 9 o'clock. So that's the Waddell modification of this whole thing. But it is getting there. So, I think that those are going to be some of the exciting side effects. So you can x-ray the lung. This was standard x-ray on the table and evaluate the images. And here's, for example, on the left is a lung that had a little contusion in the right upper lobe and significant edema. And you can see after 3 hours of perfusion, the edema clears. The contusion, of course, is still there. What's really important as a lung transplant surgeon is if you evaluate the PO2 ratio over time, 1, 2, 3 hours ex vivo, what you see in the ex vivo circuit is what you'll get when your patient arrives in the intensive care unit. Again, trying to improve the assessment and the predictability of the organ that you're transplanting. And when the lung isn't going in the right direction, you can see the lungs that we used, the oxygenation and the pulmonary vascular resistance versus the lungs that weren't used. You can see pulmonary vascular resistance climbing rapidly. So the system does tell you when you've got a problem. And here again is an x-ray of a lung going in the wrong direction where the edema got significantly worse as we perfused it. One of the important things, though, is that we had to relearn the physiology of the evaluation of the lung outside the chest without the restriction of the chest wall and so on, and with optimized VQ matching, we realized that PO2 actually drops off much later than expected, and seeing the drop in compliance and the increase in pulmonary vascular resistance is a much earlier and more subtle finding which most surgeons were not aware of. So we really do have to recalibrate how we assess these donor organs. So our clinical trial was published in the New England Journal last spring, and the results showed that we had equivalent outcomes with the ex vivo lung perfused lungs versus control lungs. So these ex vivo perfused lungs were lungs that we would not have used in our program because of concern of function, and we showed actually equivalent outcome with those lungs. To date, we've done 62 ex vivo lung perfusions, and of those, 52 were transplanted. So again, about 15% of them, you'll find that something is not quite right and they're not going in the right direction. And of course, these are the lungs that we want to figure out a way to fix with more sophisticated ways, and I'll show you that. So the number of ex vivos per year has been steadily rising in our program, and it accounts for 20% of our activity in the program and the increase in numbers that you see in the transplant. More exciting is we've got more experience in the program. We're starting to see now that we're actually getting a trend towards shorter mechanical ventilation with the ex vivo lungs and also a shorter hospital stay. In fact, many times our intensive care unit physicians would say, like, why don't you just ex vivo all of them? They seem so much smoother, and we're starting to try and tease out where these improvements are and make them more tangible. But certainly in terms of cost and hospital stay and complications, we're beginning to see the benefit. It really takes the adventure out of lung transplantation, right? Because you're transplanting a known product with a known and predictive outcome, as opposed to the sort of, we did it again, that's pretty cool. So, this is beginning to take off around the world. Vienna and Madrid were early adopters, Newcastle and Harefield. The FDA did drag their feet a bit, and as usual, and there is an FDA-directed trial now with 4 universities here. So 8 cases have been done within that trial, so hopefully we'll get that going soon. So the advantages of the ex vivo treatment gives you increased time for interventions and for assessment, but it gives you a unique ability to treat the organ outside the body. It's not in the recipient, it's not in the donor, so you can avoid systemic side effects. Drugs, there's no kidneys or liver to clear drugs, so drugs have an infinite lifetime, half time in the circuit, so you get prolonged effects. And you get the absence of the inflammatory milieu in the brain-dead donor, and that allows for recovery of the organ over time. Most importantly, you get a chance to relook at the organ and see that you have indeed fixed it and achieved what you want. We'll have huge gains right now just in, one is being able to assess the organ more accurately, but 2 is to treat simple things. The majority of lungs that are turned down are really just edematous lungs, and if we could just clear extravascular lung water, we can improve the function of those lungs. There's certainly pulmonary edema, of course, is one. Brain death associated inflammation is a huge insult that affects all organs that are transplanted. Infection and pneumonia in the lung, you can envision treating these donor lungs with industrial dose antibiotics to sterilize them, perhaps sterilize HIV or Hep C, Hep B as well. And then look at other more specific therapies for the other injuries you see. Every lung undergoes ischemia reperfusion injury. Every lung and it requires, will get an immunologic attack. So really the holy grail of this is, will we be able to immunologically modify these organs before we put them in to make them look more like self and improve the long-term outcome? And just an example too, here's a donor where the PO2 was 230 on the first hour in the EVLP. You can see a pretty edematous lung. 3 hours later, the edema had started to clear, and when the recipient arrived in the ICU, the PO2 was 430. So those are lungs that we wouldn't have used, and all we really did was treat inflammation and edema. So you can also facilitate the removal of lung water. For example, terbutaline inhalation will facilitate Mike Mathey's work showing ex-vivo lungs. You can increase edema clearance just with beta-2 agonists, and there are many other simple therapies. In our program now, we're taking lungs that have pneumonia and are starting to lavage them and treat them with high-dose antibiotics, a sort of wash and sterilize technique. And we've shown that we can take these lungs, again, pneumonia lungs turned down by our surgeons, and keep them for 12 hours. And also with our ID specialists, we're looking at protocols to look at the bacterial flora over time to show that we are able to sterilize these lungs and perhaps make them transplantable. This is the second most common reason that lungs are turned down for transplantation. So I'll just move into some of the more exciting areas that we've been looking at in terms of treating ischemia reperfusion injury. And we've been looking at the molecular diagnostics, like, do all lungs need these fancy treatments, or how do we select which lungs will need it? So looking at biopsies of lungs taken before we transplant them, we can tell you that if the IL-6, IL-10 ratio in the donor lung biopsy is low, it's going to be a good lung. If that ratio is high, it's going to be a bad lung, and your patient will do poorly. Similarly, we've done having trouble with, there we go. We found, Misaki and Raku from Japan, who worked in our lab, also found 120 other genes that are predictive of function of the donor lung after transplantation. We've also been working with Excella to develop a sort of designer chip with 110 inflammatory genes, and looking at the changes through EVLP, both pre and post, again to monitor and decide which of these genes will tell us that lung has improved in its function over time. And we're also exploring more exciting other modalities. This is a little solid phase microextraction catheter that goes into an angiocath, which we can put either into the patient, into the lung, or into the ex vivo circuit, and look at some of the metabolites over time, again to assess what's happening to the lung and look at prediction. This is probably the most important thing. Most of you are involved in cancer work, and you know the importance of personalized medicine and targeted therapy and so on. But in cancer, if you get your gene readout the next day, that's fine. You know, that's plenty of time to figure things out and so on. But in transplantation, we really need those answers in minutes. And so Shana Kelly at the University of Toronto is one of our nano engineers. They've developed this nano chip that you can hybridize your gene with. And now, instead of taking 5 hours to do your microarray or your gene finding, we can get an answer in less than 30 minutes. So now we can really start to, once we get our biomarkers lined up, assess the lung, say, okay, this lung is damaged, here's the injury it requires, treat it with a specific injury, reassess it, and confirm that it's better. Some of the work that we've been doing, and again, Steve Cassidy did some of the early work, I have to give him credit for that, and then Stefan Fischer and then Salo Martins and Pig showed that adenoviral IL-10 gene therapy can decrease that injury response, that inflammatory injury in the donor lung, and improve function. I don't have time to go through this, but Jonathan Young has just finished some very nice work showing that lungs where you do the adenoviral gene therapy ex vivo function even better after transplantation than when you do in vivo gene therapy, because you take the lung away from the host, the donor or the recipient, and you're treating with adenoviral vector ex vivo. You don't have the host immune response to the vector. And so you actually end up, so it's an incremental improvement in our ability to deliver the gene therapy. Marcelo Sippel took this to the injured human lungs, and I'm just about done. And he showed that you could improve the function of human lungs from brain-dead donors and decrease the inflammatory profile in these lungs. So we're also looking at ways now that using lentiviral vectors where we treat the lung before we implant it. These are rat lung transplants, and we've got low-level intragraft IL-10 immunosuppression that lasts for over a year. So this would be systemic immunosuppression sparing. So what the ex-vivo perfusion has done for us is we've learned a lot more about lung biology. The technological advances have certainly made this a reality, and we're able to manipulate temperature and other treatment so that we can actually begin the repair process before we transplant. I think it brings us into the era of personalizing the treatment for the organ. Right now, the ability to assess and treat organs prior to putting it in, and using more organs in the near term. But I think in the long term, it's going to improve the quality and safety and predictability of transplantation. I think the future of organ transplantation will evolve very much like blood transfusion. We don't transfuse whole blood anymore. We process it, separate the components, give the patients the right component, and quality control it, and so on. I think we'll do the same thing with organs, and we've developed a Toronto liver system. Others are working in kidney and heart. And I think that this is not science fiction. This is a reality. We already have an organ regeneration laboratory where we do our cardiac stem cell work in the Ex-Vivo Lung at Toronto General Hospital. And we've actually done a case. This was a case Bob Love called me from Chicago, had a 51-year-old on ECMO, troubles, and there's a lung in another state that was not adequate. The donor lung had significant edema. That's the donor lungs when they took them out. He said, can you fix them in Toronto and bring them back to us? We flew the lungs to Toronto General Hospital, repaired them, and sent them back to Chicago. There were the lungs on the ex-vivo circuit, and the recipient immediately and several months now after with his transplant. So the organ repair center concept, I think, is somewhere we're going to go, and we're in the process of developing that and working to provide a service. The other spin-offs will be isolated in vivo lung perfusion for cancer. Again, now we have a very reliable system that doesn't add injury, and can we revisit some of those highly effective cancer-toxic drugs to treat the lung only in our cancer patient? And Marcelo is working on projects to do that. And obviously this is an ideal bioreactor if we're going to grow new lungs. Where are you going to put the lungs? Here, this is work done by Joe Vacanti's group in Boston. They decellularized rat lungs, and there's a lung scaffold with all of the cells stripped out of it. They then put endothelial and epithelial cells into the lungs and then transplanted the lungs. So those lungs in the rat just transferred gas for about 20 minutes. It's not a home run yet, but we will get there. So you can envision if the lung's too damaged to fix, just strip it of all its cells, use your own bone marrow cells, and make a new lung for yourself. So I'd like to close by acknowledging the fact that I'm presenting a lot of work that involves the support of all of my partners in thoracic surgery, as well as a large group of research fellows, scientists, and postdocs in the Latner Thoracic Lab, and of course our clinical lung transplant group, who's a highly dedicated multidisciplinary team. Thank you again for the privilege of presenting.